In this screencast, we will discuss several EEG transients, initially focusing on normal transients. So with transients, we mean relatively short duration events that may or may not have a pathological meaning. As just said, now focusing on physiological transients. And it's very important to recognize them and label them properly. Of course, in particular, physiological transients should not be labeled as pathological. And the most common mistake is that some of the transients can be labeled as epileptiform discharges, which may to the erroneous conclusion that the patient may have an increased likelihood of seizures and eventually be labeled as having epilepsy, which is of course something we don't want to happen. Now the first transient we discuss are lambda waves. The lambda waves are, their name is derived from the fact that they look as a capital lambda when viewed in the right montage. You already learned that depending on the montage, waveforms may have a different appearance, and the lambda waves appear as a capital lambda in the double banana montage, and then they have a shape similar to this capital. They're present over the posterior areas and they reflect visual scanning of the environment. They are positive waves in the sense that the occipital areas are relatively more positively charged in relation to the surroundings, which is why they look like the capital lambda in the bipolar montage, because at that moment the occipital areas are indeed relatively more positive. Typically they appear bilaterally, but it's not always symmetrical. Now this is an example of lambda waves, and over the posterior regions right here, and this is not the bipolar montage. And in fact the lambda waves look 180 degrees, actually flipped, you could say. So this is the lambda, and the reason is that this is a source montage where the appearance of the lambda waves is different. And if you have your own EEG, you can check that lambda waves indeed have the capital shaped lambda if you look in a bipolar montage. These are artifacts, by the way, eye blink artifacts. This is another artifact. So actually there's quite a lot of artifacts in this EEG. Another waveform or transient that appears quite often is midline theta. Short duration, rhythmic, typically short duration, rhythmic theta frequency over the vertex. May last 2 to 10 seconds. You can discuss a little bit whether it's called a transient, but it's often regarded as such. It has a non-specific clinical relevance, and it's also known as midline theta of Chiganek. This is another example of an EEG with some transients. I think you immediately recognize an eye blink. This is a bipolar montage over the left frontal hemisphere and here as well. And there's one thing quite remarkable in this patient, that the eye blink is present unilaterally only. Now you can probably figure out why this is the case. This is another example of transients, or actually artifacts, showing EMG. So that is also part of the transients. So it's not an origin in the brain, but from the muscle. And it's typically present most prominent over the frontotemporal areas, because that's where the temporal muscles are located. So this is left hemisphere. This grass, it's really EMG, the same as here. So it's more prominently present in this case over the left hemisphere than the right hemisphere, but very often it's present bilaterally. And this is another transient. These slow changes, and this is a sweat artifact, most likely. It's not an eye movement, because it's only present on the left hemisphere, and it's also present over P301. So these are sweat artifacts, and that results in small changes in the voltage across the electrode skin interface, resulting in these very slow changes in the potential. It's basically a drift effect, a drift phenomenon. This illustration shows why it is important to record the EKG. This is the electrocardiogram. If you look in the EEG, we find something that almost looks like lambda waves here that we discussed previously. This one, this one, this one, very regular, and they exactly coincide with the QRS complex of the EKG. That probably shows a block as well, by the way, a bundle block, and apparently exactly synchronous with the kg. This deflection is shown, and this is most likely an electrical artifact resulting from the electrical activity of the heart. If it would be displaced slightly, so if there would be a small delay between the QRS complex and the wiggle found here, then it could be, and then it's most likely to be a pulsation artifact. So it's important to know that this is not derived from the brain, but it's an artifact from the heart. This is another example, a nearly flat EEG in a patient monitored in the ICU with the question brain death. And indeed, all the leads do not show any electrical activity except for this one. And this is an example of a pulsation artifact. So the wiggle appears slightly after the QRS complex. So this electrode, the idea is that the electrode moves a little bit on the heartbeat frequency, and that results in small voltage differences across the electrode skin interface, resulting in this artifact. It's good to recognize, of course, not to erroneously interpret this EEG as not being flat. Sometimes it can also be observed in brains that do function properly. This is a normal EEG. This is the AKG, and here over a frontal lead you also find a pulsation artifact. Of course, other reasons to record the EKG, the primary reason is to look for artifacts in the EEG. Sometimes also we find abnormal rhythms in the EKG during an EEG recording that may warrant consultation of a cardiologist. This is another example of an artifact. This one and this one, electrode pop artifacts. They are called very small, sometimes in two directions, downwards and upwards, changes in the voltage that result from small movements of the electrode. Touching could also be a cause of this artifact, when the patient or the lab technician touches the electrode. And this is T501 and this is P301. So the origin of the artifact is most likely to be O1, because that's the common one in these two derivations. So these were examples of, transient phenomena, most of them from not derived from the brain. There are several variants that do find their origin in the brain, and it's important to recognize those and label them properly. And these are the 6 most common ones: rhythmic temporal bursts of drowsiness, Schrader wicked waves, small sharp spikes of sleep, 6 Hz phantom spike and waves, and positive bursts of 14 and 6 Hz. We will quickly recap them. So the rhythmic temporal bursts of drowsiness are bursts of theta waves, maximum mid-temporal. The duration, it ranges from 10 seconds to 1 minute. And it's observed quite often, actually, between 0.5 to 2% of adolescents and adults. And an example is shown here. So this are rhythmic temporal bursts of drowsiness. It's not an epileptiform discharge. It starts quite abruptly. The frequency is constant. Amplitudes don't change. There's no spatial evolution, and here it stops. It's a physiological variant. Do not misinterpret it as epileptiform discharges or ictal activity. And to recap, the most important features that make it physiological, not pathological, is abrupt start, relatively abrupt stop of the event, but even more important, there's no change in the frequency, and it's a wide field of distribution, and there's no spatial recruitment. So it starts at this particular spatial location and it remains at this particular spatial location. Another one is SRADA, so subclinical rhythmic EEG discharges of adults. That's not so common, seen in the elderly, 50 years and older. It's also in the theta range, also abrupt onset and termination, and duration is 20 seconds to minutes. A very important transient are the wicket waves, seen over the temporal area. They appear like mu rhythm, but they are not mu. It's often unilateral and it's very short duration, 0.5 to 2 seconds. And this is a wicket. It's not wicked waves, but wicket waves. And this is an example of wicket waves in a 19-year-old male. And this is an example of wicket waves in a 74-year-old female. Very sharp, but symmetrical. The up and down slope are basically the same. There is negative phase opposition, but as discussed earlier, this is not pathological as such. Short duration over the temporal area. And indeed, it looks like mu, but it's in the wrong position, so it's definitely not mu, of course. So, physiological phenomenon. This is very often misinterpreted as an epileptiform discharge. Then there's small sharp spikes, occur during light sleep, temporal, unial, bilateral, monophasic, and they last a short duration, less than 50 microvolts. In general, you could argue if phenomena are smaller than 50 microvolts, it's unlikely to be abnormal. And these are small sharp spikes shown here and here and here, physiological. And then a phenomenon that we don't see that often, or we overlook it, 6 Hz phantom spike and waves, also in the theta range, 1 to 2 seconds. It's called phantom spike and waves because you find the 6 Hz and the spike is difficult to appreciate, so it's a phantom spike because it's not always visible. It says 2.5% of adolescents and adults. That's mentioned in many books. I find it a little bit less often, I think. It's bilateral, synchronous, and during light sleep. And this is an example of 6 Hz phantom spike and waves. So this is about 6 Hz, and if you look carefully, there is something like a spiky appearance in between. It's very often to know and to recognize because it's not an epileptiform discharge. So it's mainly during light sleep, by the way. It said on the previous slide, this is not light sleep because the patient is awake here, but it's also possible to observe it during wakefulness. And then there's a phenomenon we know as 14 and 6 Hz positive bursts. So we have 2 frequencies, 14 and 6 Hz. Short duration can be observed during awake and light sleep. And this is an example of 14 and 6 Hz. So this is the 14, and in between there's the 6 Hz. Physiological phenomenon. So that ends our short discussion about physiological transients, and later we will discuss epileptiform discharges.